And again, the intention here really was just to provide tips that I could have, in terms of how to assess these patients and how to expedite your investigations, stabilise your patients as swiftly, seamlessly as possible. So we're not going to go too much into sort of the end stage treatment. It's more focused on really the assessment, the initial diagnosis, how do we stabilise those cats that are in particularly difficult state. So broadly speaking as well, a really key objective from the assessment is to try and localise where does the problem lie. And respiratory issues can obviously be upper respiratory, which we've just spent a lot of time about. And that typically, as I mentioned earlier on, the standout thing for that is noise. So if you can hear noise, it's upper respiratory. But then we have the lower respiratory tract, so the trachea, bronchi, pulmonary tract, and then we have the pleural space, so things there, obviously reducing the amount of space available for the lungs to expand in, and then lastly, non-respiratory causes of breathing difficulties. So our efforts always with a dyspneic cat should be, in the first instance, to try and localise, well, where is that dyspnea, because that's going to tell us what we should do next in terms of investigations or stabilisation. And when a cat is dyspneic, of course, stressing it is potentially catastrophic. So we do need to be really hands-off, but in the beginning, that actually potentially quite helpful in terms of standing back, looking at the cat, listening from a distance, is there noise? This cat, who had the great name of Sergeant Pussy Willow, the things that people call their cats, had herpes virus and FIV, poor thing, so he was really debilitated flu virus cat, and very snorty, snory, breathing, nasal discharge, a lot of inspiratory effort, still breathing through his nose, even though it's struggling. We can make our diagnosis from a distance in cases like him. But in many cats, of course, we do need to specifically evaluate the respiratory tract, which we'll move on to. So we're going to observe the cat first of all. Mouth breathing generally is a severe thing to see. So obviously it can happen with stress, as we talked about this morning, but obviously cats in severe respiratory distress will mouth breathe. And again, those are the ones that we really worry about as being on a knife edge. Similarly, if we see any evidence of cyanosis, we're going to be worried about that as well. But our distant observation can also give us some other clues. So the white cat, again, you saw this cat that had a nasal carcinoma, and we can see the ocular involvement. So again, within the consulting room, we know a lot about the likely origin of this cat's breathing difficulties. And last, we've got that acidic cat on the right, abdominal distension. In fact, the preceding slide, so just to go back to this one, yes, this lovely tortoiseshell cat, a patient of Andy Sparks. This is quite an old photo, but lots of articles about dyspnea. This cat was in it. It's a great picture, and this is a pregnant cat that just was, about to give birth, and the abdomen was obviously putting pressure on the ability of the lungs to expand normally, and hence the dyspnea. So not really dyspneic in the sense of respiratory problems. So then we want to, when we're looking at a cat, try and characterise the breathing. So is the effort associated with breathing in or breathing out, or both? And often cats that have a lot of inspiratory effort, if it's silent, that tends to be pleural space disease. So pleural effusion in particular would be my sort of number one consideration there. But of course, if you have your cat like the right-hand Persian cat we saw earlier on, that you can actually hear the breathing. It's not very good audio to play, but then that's upper respiratory tract again. So listening and observing is definitely a really, really good start to these sort of patients.